Next up, it's my pleasure to introduce Raliat to you, a Group Chief Pharmacist and Clinical Director for Medicines Optimization, who's been instrumental in terms of putting together the pharmaceutical services for the London Nightingale Hospital. And Raliat will be sharing her experience from a Chief Pharmacist perspective with us. Thank you, Raliat.
Good morning. Thank you, Modgan. So my name is Raliat Onatade and I am Group Chief Pharmacist at Barts Health NHS Trust. And in March 2020, the Nightingale Hospital, based at the Excel Centre in London, became our sixth hospital and therefore came under my portfolio as Group Chief Pharmacist. So over the next few minutes, I'm going to talk to you about our experiences in setting up and running for a few weeks the Nightingale Hospital, which was one of the only Nightingale hospitals to actually have a steady stream of patients coming through. So important thing for me to say up front is that although these are my personal reflections, the running of the Nightingale was very much a team effort, and I think and on this first slide you can see right in the middle Jack Hartwell, who in his substantive role is Chief Pharmacist at the Royal Marsden and joined us at Nightingale Hospital to run the pharmacy department as Director of Pharmacy, and the rest of the team on this slide are some of our fantastic pharmacists and pharmacy technicians who provided a service to Nightingale. Next, please, Modgan. So this slide, just very briefly, is a diagrammatic representation of the Nightingale wards, and in the top right corner you can see what the ward looked like. So they did have a capacity to treat nearly 4,000 patients, although we didn't reach that. And the wards were not typical hospital wards. They were we had two wings, and each ward has 42 beds, 21 beds each facing each other, and each ward divided into bays. Next, please. And so this is a photograph before we started getting patients in, the main focus of me for this is really just for everybody just to be able to see that it was very much a field hospital, and so the way we were thinking about setting up and running the service was not a standard typical way of running the service. So we had to make a lot of things up on the hoof and make a lot of decisions because of the way that the wards were set up, and storage is something I'll come to later because that was key for us. Next, please. So on the 24th of March, which is around the time that I got the call, then these were some of our initial service considerations, not many of which did not translate into reality, but it just goes to show that what you start off with is not really what you finish up with. So we initially thought we would have 24-hour clinical pharmacy provision, and we had to make some adjustments to that. One important thing was the fact that strict infection control right from the off, so nothing that went in could come out, including medicines, drug charts, etc. Only the people could go in and come out, and that was very important for us when we're thinking about medicine supply in and out. Full CVAS in terms of ready to administer medicines, and I think Vina before has also spoken about how the use of provision of ready-to-use medicines was really important. 24-hour stores and distribution service. We thought we were going to have a full discharge process with step-down care, and we were told the clinical model did not include clinical trials. So all of that went into our initial thinking. Next, please. So this is a slide showing the same ward when we were doing a simulation, so that we could see what it would be like when we actually had patients in the bed, and the cramped nature of the wards is I think is quite obvious to see here. Next, please. This was our pharmacy department, very much a non-traditional pharmacy department. There, the first picture on my top left shows that there were hardly any desks. It was not a dispensing pharmacy, so the idea of providing a full discharge service went out of the window quite quickly. The structure in the middle, you can see, is our CD room, set up for us by some really lovely members of the army within 2 days. And the bottom left is the storage for our fluids, where we had to have quite strict security. So so again, it was very non-traditional and nothing like anything you'd expect from a standard pharmacy department. So the way that we had to work was again very different to normal. Next, please. So I'll spend a little bit of time on this slide, because this was the actual reality about setting up a new pharmacy department within the hospital, really and truly within 10 days. For us in pharmacy, I'm sure most of the listeners will know, staffing is key for us. So making sure that we got the proper recruitment, the numbers, the expertise, the training, the rotas, the shift working. We decided to match our shifts with the doctors and nurses and the other clinical staff on the wards, which again was different from us, but actually worked very well. Although it wasn't normal ways of working for us. We had to consider the fact that we didn't have a stable team. We had a core stable team, but because we had staff coming in from and volunteers from across London, then your team members would changed every week, and so we had to take that really into consideration in terms of actually our communication. Setting up all of the normal support systems was important. I personally had never had to do much with setting up of oxygen. There was a lot of support from region with a lot of the setting up processes, and I did learn a lot about oxygen supplies. Medicine storage on wards. If I were to leave, one of a handful of tips would be actually getting our medicine storage sorted. We thought we had, but unfortunately, a lot of the storage that we thought we'd set up needed to be repurposed for other uses, and so and that did cause quite a lot of difficulties with us and the nurses, and so we had to put a lot of pharmacy resource in just for the medicines management. I've mentioned fluid storage. Where our fluid was stored was in an area which had quite a lot of throughput in terms of staff. So we put security on both within that area 24 hours, and again security for pharmacy and on the wards. The pharmacy department was a repurposed set of offices really, and so we had to put in particular security. Clinical governance and medicines governance. Again, had to learn a lot about what the real regulations and the law was, as opposed to what we considered best practice, because a lot of the things that we would have liked to do we couldn't, and so we went back to how do we comply strictly with the law, and in some cases actually where we suggested lessening the medicines and governance processes, then our nursing colleagues actually came back and said that they wanted them tighter, which was quite a good lesson for us. We had no running water on the unit, which was not only an issue for us, but also for our other clinical colleagues. And I cannot rate highly enough the generosity of our London pharmacy colleagues and pharmacy colleagues from the region. We could not possibly have done this without them. Setting up a pharmacy department without the support from all of our colleagues and friends who really saw the Nightingale Hospital as a unit for London was just essential. Next, please. So. in terms of our clinical pharmacy team, what was really interesting was that when we stripped down everything that we needed to provide from a pharmacy department, it came really down to two things: your medicine supply and shortage and your clinical input. This diagram shows how we thought we would run our pharmacy clinical model, with one critical care specialist pharmacist looking after up to 126 patients, but with a smaller group looking after each 42 patients, with 2 pharmacists and 2 band 5 pharmacy technicians in it looking after 42 patients, so looking after a ward. In the end, we didn't get to test this model fully because we did not at any one time have more than about 42 patients on the ward. Next, please. So again, coming back to pharmacy, I think in the right hand corner you can see Isa, who's our pharmacy technician, and the role of the pharmacy technicians, and again Rena's alluded to this, the role of the pharmacy technicians on the unit support medicines management was just critical because of the changed nursing and doctors ratios, as well as the difficulties with storage. And so having our pharmacy technicians to support the use of medicines on the wards was really one of the most important lessons that we learned. Next, please. So I'm not going to dwell on this this slide. These are basically questions, and the point of this slide really was the importance of being prepared for the unexpected. What I will talk about a little bit is just, I think, as you know, at the beginning, I said that we were told there were going to be no clinical trials. And then just before we started, we were asked, can we start dispensing clinical trials from the next day? And so we had to very rapidly put a lot of things in place to try and be able to start with the recovery trial. So this is really around being prepared for the unexpected and finding answers to questions that you didn't even consider that people might want to ask for a unit such as Nightingale. Next, please. So what went well? I've spoken about a few things here. The volunteers and the support from across London, as well as from our regional colleagues, was important. The communication between, in our pharmacy huddles, the multi-professional clinical forum which went on every day, which enabled very agile responses to any challenges that we came across. And I think we all know that the provision of critical care medicines in a ready-to-use format is actually something which we are now being asked as a pharmacy team to continue to provide, even outside of a pandemic. Next, please. We now moving to the end. We are now in hibernation until March 2021, and these are some of the issues that we've dealt with in order to make sure that we've got a good detailed reactivation plan, including learning from the Army in terms of their standardized processes. Next, please. And finishing off in terms of what's important, I'm going to mention 2 specific things here. One is that what was really clear to me is that you cannot plan for a 4,000 bed hospital. We just couldn't. So in actual fact, what I had to do was just scale myself down, scale my thinking down, and start planning for a normal hospital. If we were going to run a 500 bed hospital, what would we need? What would we do? And then assume that that's going to scale up. Establishing the roles and structure of the unit, regardless of how many beds you've got or how many patients you've got, was important, and building on your existing processes, structures, networks, and pulling that experience in to build this new department what was key, as well as putting in place the support for your people. Cannot emphasize that enough. And I think, next please. So yes, I think so that was my experience and reflections on setting up the pharmacy department in Excel London. And I just need to add by saying it was a fantastic experience, but one which hopefully we will not need to experience again. Thank you.
Thank you, Raliat. Clearly a lot of work in a very, very short period of time, and planning has been critical for this. Thank you so much for sharing your experiences with us.